Right. Thank you, David, for that very kind introduction. Thank you, President Duval, for the honor of presenting this opening address at the 75th anniversary meeting of the Canadian Anesthesiologist Society. Merci, Président Duval et les organisateurs, pour l'honneur de présenter ce discours d'ouverture à l'occasion de l'anniversaire de la Société canadienne des anesthesiologistes. Just to begin, I have no personal financial conflicts, but as a result of our research, the University of Toronto holds several patents. In addition, we've received software donations from Cogstate for clinical studies, and the research I present today will be supported by CIHR and CARF. So what would the founder of the CAS, Harold Griffith, think if he were here today? I'm sure he would feel great pride because he believed that the advance of anesthesia could best be achieved by communication. And just as he's envisioned, the CAS has become a home, a place where we communicate our dreams, aspirations, and where we launch our big ideas. Over the past 75 years, there's been remarkable advances: discovery of safer drugs, improved monitoring, and the development of anesthesiology as a profession. All these innovations have dramatically improved anesthetic-related mortality. And over the next few days, we'll celebrate this rich heritage. And as we look back, we'll see that time and time again, science and innovation were at the heart of our achievements. That's because discovery changes us. It changes us as individuals because new truths force us to abandon old, outdated assumptions. Discovery changes us as a society because, armed with new knowledge, we can work together to conquer seemingly insurmountable problems. And finally, discovery changes us as citizens because it enriches the fabric of our everyday lives and helps us position Canada on a world stage. So my goal in speaking to you today is to remind us that we have a responsibility to carry this rich heritage forward. Yes, let's celebrate our history and accomplishments, but let's also think hard what it means to be anesthesiologists in the 21st century. My key message is that we will best serve our patients, but also ourselves as professionals and society at large by embracing science and innovation. Now, these terms, science and innovation, sometimes conjure up images of test tubes, math equations, lab animals, but today we're referring to, more broadly, new methods, big ideas, new processes, and products that create a positive impact. And I'll illuminate this message using 3 historic examples, followed by 3 more contemporary modern examples. The historic examples all have something in common, because initially they appear to be only small wins with local impact. This scenario will probably feel very familiar. We all sometimes feel that our discoveries are small. But what I hope to show you in telling you these stories is that even small wins have the potential to be international game changers. Discovery creates a ripple effect that over time can change the course of patient care, our profession, and even history. And I therefore encourage you to celebrate your own small wins because that's how every major discovery begins. So we'll begin by thinking about the work of the CAS committee that was established in 1970. At that time, the academic chairs in Canada were petitioning the CAS to develop guidelines, the reason being anesthesia outcome varied markedly across the country. Dr. Douglas Craig, a member of the committee, recounted that the very idea of safety guidelines was highly controversial at the time. There was concern guidelines would be overly prescriptive, they would threaten autonomy of physicians. Some argued formal guidelines would increase medical legal risk for anesthesiologists. But the committee persevered because they believed that all Canadians, wherever they lived, deserved the same level of basic care. The members of the committee were courageous, and despite heavy criticism, the guidelines for basic standards of practice of anesthesia was published in 1977. This slide shows the 1981 guidelines. We have a national hunt underway for an original copy of the first version. These were one of the first anesthesia guidelines in the world, and since then, organizations such as the American Society of Anesthesiologists, Australia and New Zealand College of Anesthetists have followed suit. In fact, only 1 month ago, the World Health Organization, together with the World Federation of Societies of Anesthesiologists, published the first ever standard that is applicable to all anesthesia providers around the world. This report is first authored by Adrian Gelb. The safety guidelines pioneered in the 1970s by CAS was well ahead of its time, and this small win created a ripple effect that is still having a worldwide impact today. The CAS has led the way because its members had the courage to do the right thing. My second example of how we can best serve our patients, ourselves as professionals, and society by embracing science and innovation relates to CARF, or the Canadian Anesthesia Research Foundation. This organization has supported generations of investigators, and the importance of these awards can't be overstated. For example, take our own David Mazer, now a well-recognized, highly respected researcher. But David wasn't always the international sensation he is today. Back in the day, David had finished his residency in Toronto and a 2-year fellowship at UC San Francisco, and while he was struggling to decide what to do with his career, he received a $10,000 award from CARF. It changed his career trajectory, bringing him back to Canada, where he established a research program at St. Mike's Hospital. Recently, Dave's been investigating blood conservation in patients, and in 2008, he published the BART trial in the New England Journal of Medicine, a report that showed the dangers of aprotein by identifying an association between death and aprotein. David recounts on the day the study was published, sales of aprotein plummeted, and the drug is no longer used. Again, early this year, David published another landmark study in the New England Journal, redefining the trigger for transfusion of cardiac patients. Again, this study will have global impact because it will prevent patients from needlessly being exposed to the dangers of red blood cells, and it will save healthcare dollars. Now, David was asked recently about the backstory on these high-impact studies in his career, and despite the millions of dollars he's received in research funding, he firmly declares that the most important grant he ever received was the $10,000 Sheraton Award from CARF. To this day, he recognizes with gratitude his own small win that produced that ripple effect that has lasting impact. The third example of historic innovation was a decision made in the 1960s by the Department of Anesthesia at McGill University to create a position for a director of anesthesia research. This decision has helped to establish Canada as a leader in neuroscience because, in effect, it created the birthplace of a generation of Canadian neuroscientists. This ancestry can best be explained in graphic terms using a family tree or neurotree. Neurotree is a program that's available online that illustrates the training pedigree of neuroscientists. So in 1963, McGill recruits a young investigator, Chris Krenovich, for the new position, and he served as director of anesthesia research for 35 years, and his work was exceptional. For example, he first identified GABA as the inhibitory transmitter in the brain, and this is a system that we manipulate every day in the operating room when we administer anesthetic drugs. Those drugs increase GABA's effect, causing profound neurodepression, the type of depression that's required for patients to tolerate surgery. Dr. Krinovich's discoveries were recognized by awards such as the Gairdner Foundation, considered to be the forerunner of the Nobel Prize, and the Order of Canada. So how is this level of exceptional success even possible for a Department of Anesthesia in Canada and a single investigator? Well, just as life does not develop in a vacuum, discovery does not develop in a vacuum. Rather, research excellence begets research excellence. These concepts are somewhat reminiscent of the work of Rudolf Virchow, the German scientist who proposed the original cell theory. He showed us that all cells come from cells. And just as cells beget cells and research excellence begets research excellence, Dr. Krenovich's success is not so surprising when we understand his pedigree. Virchow was, in fact, Krenovich's scientific great-great-grandfather and the scientific great-great-grandfather of the Department of Anesthesia at McGill University. Virchow had trained Sir Charles Sherrington, Nobel Prize 1932, who trained Sir John Eckel, Nobel Prize 1963, who trained David Whittington, who trained Dr. Krenovich. And Dr. Krenovich went on to produce his own scientific offspring, who helped to establish neuroscience programs across Canada, including Calgary, Edmonton, Victoria, London, Toronto, Laval, University of Montreal. And as a result, these offspring are now international leaders in neuroscience. So a key decision made in the 1960s by the Department of Anesthesia produced a ripple effect that extends well beyond anesthesia-related sciences today. This story illustrates the importance of sustained support for excellence and innovation. But there's a second point to telling the story that illuminates how we as anesthesiologists can create our own destiny. All those neuroscientists who could trace their roots back to Dr. Krenovich needed money to run their laboratories. And for decades, Canada's government had flatlined federal support for science. As a result, Canada was losing its competitive edge compared to its international peers. Excellent neuroscientists were being forced to close their labs. So you can see that excellent training and compelling problems were not sufficient. The neuroscientists need to garner additional support to do their work. And they were determined to create their own destiny. So they banded together and formed the Canadian Association for Neuroscience, or CAN. CAN is now one of the most influential groups in Canada, and it's influential because it engaged the public at all levels, including the provincial and federal governments. The members explained to government leaders how scientific endeavors and innovations in the realm of neuroscience would help the leaders to address issues that were important to them, such as the rising tide of dementia and depression in Canada. Working with government leaders, CAN and its members were able to promote and advance their own interests, as well as those of the Canadian population. This is key. CAN recognized by identifying important problems that needed solutions was not enough. They had to work with the leaders to address and help address the leaders' concerns. Their lobbying started to create fertile ground on Parliament Hill to support basic science research. And at the same time, Dave Naylor, a former president of the University of Toronto, was asked to chair a federal advisory panel on healthcare innovation. It was Canada's first review of fundamental science. And in its report, the panel called for sweeping changes, including dramatic increases in funding for basic science research. Calls to support the report were heard echoing through the halls of Canadian universities. And the science community has never been so mobilized and galvanized to support a cause. The report was published in 2017 and accepted in principle by the federal government and is in effect today. And at a time when many countries are restricting funds for science, the Naylor report continues to change the Canadian narrative in a way that we can all be very proud. Like Medicare, science and innovation will be part of the future fabric of every Canadian life, helping to position Canada as a leader on the world stage. And in a similar light, we as anesthesiologists need to create our destiny by engaging hospital leaders and working with ministries to address problems that are important to them, not simply to focus on problems that are important to us. So let's now turn to more contemporary examples, and I'll begin by sharing a personal story about my lab team. Similar to David Mazer, ours begins with a small grant from CARF. And also like David's experience, my lab team has seen firsthand the ripple effect that occurs when small scientific wins evolve into bigger discoveries. The story goes like this. Our memories are incredibly resistant. You know that salient events are etched into your brains for decades, sometimes a lifetime. And given the remarkable resilience of memory, it's perplexing that some patients experience unexpected memory loss after anesthesia and surgery. And these deficits can take the form of delirium in the early days or a subtle post-op cognitive deficits that last for weeks to months. They're important to understand because they're associated with poor long-term outcomes, increased costs, hospitalization, and even mortality. And it's long been assumed that we can't do much about the problem. However, we're now learning that that is an old assumption. My own views about post-op cognitive deficits have changed dramatically, and that change started with a visit from a graduate student, Bachara Saab. So Bachara was working in the lab of John Roeder, studying the biology of memory, and he'd been anesthetizing mice so they could inject memory-altering drugs into the brain. But Bachara noticed something very odd. Among the mice that he examined days after he had only treated them with anesthetics, he found that memory performance was subtly impaired. Their overall behavior was fine, but subtle probing revealed subtle deficits that last for days. These results were troubling. Like many of our colleagues, Bachara and I had assumed that once the drugs were eliminated, the brain goes back to baseline state. But Bachara repeated these studies again and again and obtained the same results. So a new truth was emerging, forcing us to abandon an old assumption. The drugs were causing subtle but persistent deficits in the mice. And at the same time, evidence was mounting from other investigators, Deb Culley and Greg Crosby, that exposure to commonly used drugs triggered changes in the brain that lasted long after the drugs were gone. Was it possible that exposing patients to anesthetic drugs was causing the same deficits to those Bashir and others had seen? An even more striking example of a sustained effect to an anesthetic drug came not from anesthesiologists, but from psychiatrists who produced a landmark study that showed a single treatment with ketamine reduces depression, and that effect lasts for weeks. So as a result of these converging lines of evidence, we became very interested in understanding how anesthetic drugs cause persistent changes, particularly memory loss, and wanted to identify prevention strategies. Agnes Zurich, another graduate student, was studying the receptors activated by GABA, the very receptors that Dr. Krinovich showed inhibit brain cell activity. And she studied the brains of mice long after the drugs were eliminated, and she observed that there was physical changes in the brain itself. The anesthetics had they'd left an imprint, and they had triggered a change in the brain cells, and there was too many of these sensors for GABA now being expressed on the surface of the neurons, and these extra receptors were oversensing GABA, causing that subtle brain fog, such as memory deficits that we see in our patients. So the molecular basis of memory loss after anesthesia was starting to reveal itself. Another talented investigator in the lab, Dianchi Wang, asked the question, well, can we prevent this overexpression of GABA receptors after anesthesia? And he knew that dexmedetomidine is the only drug available that reduces the incidence and duration of delirium. It led him to wonder, well, if dex prevents delirium, and if overexpression causes memory loss, does dex prevent overexpression of GABA receptors on the surface of the brain? And just as he had postulated, dex prevented that anesthetic-induced increase in GABA receptor overexpression, and subsequent behavioral studies confirmed that dex prevents anesthetic-induced memory loss in the animal models. So we and others are now studying the utility of dex and other classes of drugs that inhibit those overexpressed receptors for prevention and treatment of cognitive deficits after anesthesia and surgery. So we see how discovery builds upon discovery. From Dr. Krinovich to Becerra to Agnes to Dianchi, we move forward by constantly building on each other's small wins to generate new knowledge that changes and discards old assumptions. New knowledge can also change our professional societies. In fact, the American Society of Anesthesiology has recently launched a program to inform patients about the risk of cognitive deficits and is investigating mitigation strategies, as suggested by the Perioperative Health Initiative slide shown here from the website. So my final example, I want to talk about how we can use technology to answer big questions, problems that are both important to us as leaders and to society. Of course, there's numerous big problems in our field from which we could choose, including the opioid crisis and the rise in chronic pain. But the big problem I had in mind is this. The population's need for anesthesia care in Canada exceeds the ability of anesthesiologists to provide such care. If we want to maintain physician-led anesthesia care in Canada, we need to work with hospital CEOs and the provincial ministries to predict and plan anesthesia care provision in the future. Science and innovation will play a major role. And in fact, 2 young anesthesiologists in Toronto have some very creative ideas about how we can extend our services. Dr. Fahad Alam and Clyde Matava have been leading efforts to use virtual reality to train physicians. Virtual reality refers to an interactive computer-generated experience that takes place in a simulated environment, and it can incorporate auditory, visual, tactile, and other forms of sensory stimuli. Virtual reality, or VR, could be particularly helpful for training anesthesiologists who work in remote or rural practices where clinical case volumes are low. Physicians working in these practices frequently work in very challenging circumstances, serving high-needs populations. In Ontario, the provincial ministries are paying very close attention to the needs of health to rural populations because they have a higher mortality rate, lower life expectancy, poor health indices relative to urban populations. The disparities are particularly evident for Indigenous populations. Anesthesiologists can contribute to solutions for positive change. So this is just an example of a video that Clyde and Fahad are developing. So imagine you're working in a small community as a family practice anesthetist and you want to learn or refresh your skills on the management of the traumatized airway. This short video shows you a simulated teaching environment that the learner would see in 3D for fiber optic intubation for a patient with a traumatized airway. Oh, darn. Can you just see if you can play that video? So what it's going to show is a care provider coming into a trauma bay and seeing the patient and assessing them. They see the monitors, they see the saturation falling. They can reach out. No, it's not going to work. We'll move on. That's too bad. Oh, man. I tried to do this so many times to get this video to play. Anyway, you come in, you see the patient, you turn on the monitors, the sats start to drop. You're offered an oxygen mask, which you put on, and then a hologram comes up, and you choose what your next move is. Do your primary assessment. Sats are still falling. What's your choice? Your airway management techniques are there. He picks up a fiber optic intubation, and you can see the airway on the screens as the learner works through the training scenario. In the future, help will be more direct through the use of augmented reality, and this is what they're working on. So imagine a young physician in rural Canada, say Kapuskasing, 14-year-old boy comes in with sustained serious injuries in a crash. The patient requires aggressive resuscitation and procedures that this healthcare provider is not very familiar with. During the resuscitation, the young physician puts on a headset with 360-degree camera and an audio system, and quickly he connects to the trauma team leader at Sunnybrook. The trauma team leader also dons a headset and is able to see in the first person exactly what the rural physician is seeing in an immersive 360 environment, as if the Sunnybrook physician is standing in the trauma bay. And through virtual reality and immersion, the trauma team leader can see and hear experiences just as the rural physician is seeing the experiences with the trauma patient, and can talk and guide the emergency physician through the resuscitation process. This is very real and will be happening soon, but in fact, with further advance, they can literally provide a guiding set of hands as holograms appear in the rural physician's view, which guide the placement of endotracheal tubes, another hologram that shows trajectory for central line insertion, chest tube insertion. And the same level of support is available to the local surgeon who takes the boy to the operating room for emergency saving surgery. This scenario is not that far off from reality, and anesthesiologists now are leading the way in developing this technology. In fact, Stuart Iglesias, a family physician who works in Bella, a remote region, wrote, "If there's a solution to the provision of advanced procedural care in rural settings, the brightest hope is anesthesia. Anesthesiologists can lead other specialties, including obstetricians and surgery, to help train and retrain rural physicians in Canada and thereby address a major national need." And Dr. Iglesias is right. We can lead other specialties in demonstrating the role for new technologies and approaches. The CAS can also provide a platform for the launch of these new technologies in a home where family practice anesthesiologists who work in low-volume environments can gain support. And along the same lines, as we scale up capacity in rural centers through partnerships with allied health professionals, we need to develop and use new technologies to train and maintain the skills of these professionals. So I hope the 5 examples illustrate how we can best serve our patients, our profession, and society at large by embracing science and innovation. And in fact, there is no alternative to doing so. We live in an extraordinarily fast-changing world. Exciting and challenging times are ahead. And if we as anesthesiologists don't innovate, the profession will cease to exist. Roles will be taken over by others, and it's unlikely to be a gentle demise, will simply be pushed aside in the name of progress. But how can we accomplish this evolution? The 5 examples I've described today can be summarized in these 5 points. The CAS guidelines taught us that we have to have the courage to do the right thing. Dr. Mays taught us, let's celebrate our small wins. And Dr. Krenovich's legacy showed us that we need to lead the leaders. My team showed that we need to build relentlessly, little by little, on each small success, and the virtual reality taught us to tackle big problems. So in closing, let's return to Harold Griffith, founder of the CAS, who said, "Our democratic way of life compromises more than scientific knowledge and technical ability. It demands of anesthesiologists, as of other citizens, goodwill, cooperation, patience, tolerance, and mercy. All these make up the art of anesthesia." And I would say today that all these things also make up the science of anesthesia. As anesthesiologists, we've dedicated our lives to one of the greatest callings, the relief of pain and suffering. And history's shown us that when we work together in the spirit of goodwill, we can conquer seemingly insurmountable problems. We need to support innovation to create that ripple effect that will change the lives of our patients, the course of profession, and even our country. Our ability to work together and embrace science and innovation to tackle big problems will determine our destiny as anesthesiologists in the 21st century. Thank you.